Good morning, everyone. Now call the Standing Committee on Public Accounts to order. My name is Kelly Regan. I'm the MLA for Bedford Basin and chair of the committee. Just a reminder to everybody to put your phones on silent. Before we do introductions, I'll just for folks who have no life and like to watch Ledge TV, I just want to explain that we'll be holding our public accounts meetings in here for probably the next year or so, is what we're hearing, while some renovations are undertaken to Ledge TV. And yes. So just so people are wondering, this is public accounts. We're just meeting in the committee's room for the foreseeable future. The percussion is provided by I don't know what in this building, but we do have musical accompaniment today. So with that, I will ask my fellow committee members to introduce themselves, beginning with Mr. Young.
Good morning, everyone. Nolan Young. I'd be the MLA for Shelburne.
Mr. Taggart.
Good morning, everyone, and welcome. Tom Taggart, MLA for Colchester North.
Mr. McDonald.
Johnny McDonald, MLA for Hants East.
Ms. Sheehy-Richard.
Good morning and welcome, everyone. Melissa Sheehy-Richard, the MLA for Hants West.
Mr. Palmer.
Good morning, everybody. Chris Palmer, MLA for Kings West.
Mr. McGuire.
Good morning, everyone. Brendan McGuire, Halifax Atlantic.
And Ms. LeBlanc.
Good morning. Susan LeBlanc, MLA for Dartmouth North.
So, I would note that we have officials from the Auditor General's Office, including the AG herself, Legislative Council Office, Hansard, and the Legislative Committee's Office here in attendance as well. On today's agenda, we have officials with us from the Department of Health and Wellness and Nova Scotia Health regarding the impact of government expenses on ER understaffing. So I will ask the witnesses to introduce themselves, beginning with Deputy Minister Lagassé.
Good morning, everyone. Jeannine Lagassé, Deputy Minister of Health and Wellness.
Ms. Penney.
Good morning. Tanya Penney, Senior Executive Director in the Department of Health and Wellness.
Ms. MacGibbon.
Good morning, everyone. Eileen MacGibbon, Vice President for Operations for Central Zone.
And Dr. Munroe.
Good morning, everyone. Tanya Munroe. I'm an emerge physician and Senior Medical Director of the Access and Flow Network.
And we also have with us in the background Mr. Coates.
Hi, everyone. Eric Coates, Clinical Transformation Director for Central Zone, as well as Interim HIED Director.
Thank you very much. And Ms. McCormick.
Good morning, everyone. I'm Bethany McCormick, and I'm the Vice President Operations in the Northern Zone for Nova Scotia Health.
Thank you, and sorry about the musical chairs there, but thank you very much. So I will invite Deputy Lagassé to make her opening remarks, and then Ms. MacGibbon. Deputy Lagassé.
Thank you, Madam Chair and members of the committee. I would like to thank all of the witnesses from NSH and Ms. Penney for being with me here today. Emergency departments are one of the most well-known areas of our healthcare system. Most of us, and arguably most Nova Scotians, have likely found themselves needing care in an emergency department at some point in our lives. The reality we face in Nova Scotia and across our country is that our emergency departments are facing more demand than ever before. It's not as simple as adding more staff to existing emergency departments. Our healthcare system is complex and interconnected. Easing the pressures at emergency departments across the province requires changes in several areas. That's where strong partnerships and a full system response become critically important. As committee members are aware, the department and NSH each have different accountabilities and fulfill a different role related to the healthcare system and emergency departments in particular. There are also other partners with us in the system, and we are all committed to making changes that will improve the healthcare Nova Scotians rely on. I greatly appreciate and value all of our partnerships. Our emergency departments need to be there when people have an emergency. That's why we're working together to make changes that will ease the pressures we are facing. One of those changes include a new program called Single Paramedic Emergency Response, or SPEAR, which allows paramedics to treat low acuity patients on scene without transport to hospital. That means those patients don't have to go to the ED at all. It may include a temporary after-hours unit near an ED for those who need care, but not emergency care after they've been triaged. That is something our colleagues at the IWK have been working on. It may also include care at a mobile primary health care unit, or at one of the 4 urgent treatment centres in Parsborough, Annapolis Royal, Northside, or Bedeque, where people can seek care for unexpected, non-life-threatening health concerns that require same or next-day treatment. It means providing care for Nova Scotians that is ready, responsive, and reliable when they need it. It means improving how we bring people into our hospitals and through them, and how quickly we get them back home or into other levels of care when they need it. It means improving placements for home care, long-term care, and more long-term care beds. And most of all, it means training, recruiting, and retraining healthcare staff. These are simple things to say, but they require a huge lift from the entire healthcare system. I can say that together we are working on every single item I've mentioned today. All system partners are committed to change. Over the past few weeks, Minister Thompson, Nova Scotia Health Interim CEO Karen Oldfield, and I have been going to communities across the province to engage in conversations on healthcare with members of the community. Nova Scotians have told us about the frustrations and challenges they've experienced while accessing and receiving care. They've asked about streamlining recruitment, about working past retirement, about creating teams of professionals to provide better care in communities where they live. They've demonstrated an understanding of the challenges before us and have acknowledged it will take us time. Their challenges and the solutions that they put forward are informing how we are working on our priority items identified through our strategic plan, Action for Health. These include improving access and flow across the system, addressing health services and models of care, modernizing our physical and digital infrastructure, addressing inequities in our system, both for diverse communities and diverse healthcare workers, and transparency and accountability. While I'm proud of the work that has been done so far, I am very aware that there is much more to be done to create a healthcare system that Nova Scotians need and deserve. We are learning from our challenges to create opportunities, to do things differently, to offer better care. The way we have always done things is not working. The time for change is now. I want to thank all of the workers across our healthcare system and through government for their dedication and their efforts to help us find these solutions. Together, we will transform our healthcare system. Thank you.
Thank you. And now we will hear from Ms. MacGibbon.
Good morning. Thank you, Madam Chair and members of the committee. We're very pleased to be here with you today. We're here to speak about emergency care in the province, and to begin, I'd like to acknowledge the many people doing that work right now and every day. Nurses, paramedics, pharmacists, doctors, and many others caring for the people of our province on their most difficult days. Early in the pandemic, they were publicly celebrated, but they remain just as deserving of our thanks today. Nova Scotians want and deserve reliable access to care both for their day-to-day needs and in unexpected situations. Across the system and with our partners, we are working to ensure they have those options in their communities and an enhanced ability to benefit from resources across the province. We know that uncertain access to primary care has meant that for some, emergency departments were the only option to see a healthcare provider. So a year ago, we introduced Nova Scotia's first urgent treatment centre in North Sydney. Urgent treatment centres provide care for those with unexpected, non-life-threatening health concerns that require same or next-day treatment and are available to people with or without a family doctor or a nurse practitioner. In its first year, the North Sydney site has seen more than 6,700 patients. Providers say that the care is rewarding and patients are happy with this option. Surveys of users to date have indicated that 97% are very satisfied or satisfied with the service. 80% indicated they would otherwise have to wait for their family physician appointment or go to the emergency department, and 99% indicated that their health care needs were met. We have since expanded that model to sites in northern and western zones of the province. In rural communities of Neils Harbor and Canso, we are trialing virtual physician support via the EHS Medical Communications Center physician to allow emergency departments to remain open when local coverage is not available. Virtual physician support allows both EHS and Nova Scotia Health to use existing resources to continue to provide service in rural communities instead of needing to close the emergency department. Elsewhere, we are piloting the use of virtual care at Colchester East Hants Health Centre to reduce wait times for Nova Scotians waiting in the emergency department with health concerns that can be appropriately treated through a virtual visit. Virtual Emergency NS is fully integrated with in-person care at the facility, and patients requiring further assessment are treated by the on-site emergency care team. This option is now offered as well at Yarmouth's emergency department. We have also opened access to virtual care NS to all people on the Need a Family Practice Registry. And while we understand that demand is high, it offers an alternative to having to visit an emergency department for some primary health care concerns. Of course, conventional in-person emergency care is critically important, and we are working every day to support and enhance it. The biggest factor behind the overcrowding seen in our emergency departments is often the hospital's inability to admit patients to beds inside the hospital, rather than anything occurring inside the emergency department. We are addressing this at local and system levels, for example, through the Care Coordination Center known as C3, currently operating at the QE2, which will be expanded across the zone and the province. The Access and Flow Network, co-led by Dr. Munroe, who is with us here this morning, is focused on optimizing our policies and processes to ensure that every day a person spends in hospital contributes toward their recovery and discharge. Staffing and ensuring physician coverage for our emergency departments has often been difficult and required hard choices, but it is a priority. I want to assure you that budgets have not been a limiting factor. We have the funds available to fill vacancies and ensure shifts are fully staffed. It's the actual human resources that have been scarce. At times, it's necessary to use nurses and other staff from external staffing agencies, either to fill gaps or to ensure our own staff are able to take a much-needed vacation. This comes at a cost, but we believe it is the right thing to do to be able to offer care when other alternatives have been exhausted. In the same way, we often use locum physicians to provide the coverage required for some smaller emergency departments to be open. Our system is in a period of transition, and like other parts of Canada, there are strains that are affecting our staff, doctors, and patients. However, we believe the actions we have in motion are creating the foundation for a reliable and sustainable emergency care system in Nova Scotia. We look forward to your questions.
Thank you so much. And we do have one introduction that we haven't made yet. With us is Ms. Hanson.
Thank you, Madam Chair. My name is Susie Hanson. I'm the MLA for Halifax Needham. Welcome.
Thank you. So how this works is we will, each party will question for 20 minutes. When that 20 minutes elapses, our witnesses may be in the middle of an answer. I'm not being rude, but I'm going to interrupt you, and we'll move on to the next party, just so you know. So we first begin with the Liberal Party, and you have 20 minutes, so you have till 9:34, and we begin with Mr. McGuire.
Thank you, Madam Chair. And as I always start out with, I have a lot of questions, so I ask that the witnesses keep their answers direct, please. So my question is, it's just a quick question. Currently, what is the average wait time for a child in the IWK emergency room to be seen?
Deputy Lagassé?
I don't have the exact wait time number, but I do know it's considerably higher than it has been in previous years, that they're seeing an extremely higher volume than usual right now.
Mr. McGuire?
What is the average wait time for the emergency room, for emergency rooms across Nova Scotia?
Ms. MacGibbon, would you have that information?
Dr. Munroe, did you ask?
Dr. Munroe?
They're far too long, Mr. McGuire, but I don't have the exact numbers in front of me.
Sorry, the microphone wasn't on. Dr. Munroe?
They're far too long most days, in all honesty. I don't have those exact numbers in front of me because they are highly variable depending on system demand and actually something as esoteric as day of the week.
Mr. McGuire?
In the last month, how many hours were ERs closed across Nova Scotia?
second. Ms. Penney? Or do you have that information?
Yeah, so the ED closure report from an accountability perspective will be out. I think it's being tabled sometime before the end of the year, as per the legislation. But I do know that 19 out of 38 emergency departments were open for at least for their entire 100% of their scheduled hours, which was on par with last year's report. And a further 12 emergency departments were open for at least 75 hours of their scheduled hours.
Mr. McGuire?
So the question was, in the last month, how many hours were ERs closed across Nova Scotia? Not how many met the 75 or 100%. How many total hours were ERs across Nova Scotia closed in the last month across Nova Scotia?
Ms. Penney?
So I apologize. I didn't specifically answer the question, and I don't have that level of data, but we can certainly get it for you. I have from the last year.
So I will ask the clerk to make a note of that particular item. Mr. McGuire.
How many notices of overcapacity has the department released over the last month?
Deputy Lagassé.
I don't believe that we've released any. Notices the department would not release those.
Mr. McGuire.
Okay. How many notices of overcapacity have come to the public for emergency rooms over the last month?
Ms. MacGibbon.
Are you speaking of public service announcements indicating that we are in a, yeah, so I think over the past month, there would have been one. I'm aware of one that we made through our communications group.
Mr. McGuire?
Are you saying that that NSHA has only released one, or you're saying that only one has been released to the public?
I understand.
Ms. MacGibbon, and that's the other thing I should have said from the beginning is I have to call on you so that we can open your microphone. So, Ms. MacGibbon.
Yes, I believe there was one in the past month.
Mr. McGuire.
So I can tell you that I've retweeted and all that stuff more than one over the last month from overcapacities and warnings. How many warnings or how many notices have been put out encouraging people not to visit the emergency room because of it being overstretched or overstaffed in the last month?
Understaffed.
Understaffed, sorry.
Yeah.
Overstaffed would be nice. Understaffed.
Ms. MacGibbon?
Yeah, I'm sorry. I'm not sure. I'll have to check to see how many we would have indicated, but I thought we had one that for Central Zone. Now, maybe there have been more outside of Central, but I'm aware of one for Central Zone in the past month.
So I will just say that we have a series of questions here that have been unable to be answered, and I think that perhaps we have I'm assuming that your comms teams are watching these, so perhaps if they could send the information to you so we could get that information at the meeting today, that would be great. Mr. McGuire.
So these are very simple questions that I would argue that individuals in senior management positions within the Department of Health and the Nova Scotia Health Authority should be able to answer. And I think there's an issue that when we can't say, when we can't get a definitive issue or answer in this committee on things like emergency room closures, access to emergency rooms, IWK, and things like that, I think there's a big issue. I will note that we did ask for the CEO, Karen Oldfield, to attend this, and again, not here. And I would, no offense to Ms. MacGibbon, sorry, but Madam Chair, the response was, I thought, Central Zone, and we're asking questions for the entirety of Nova Scotia Health Authority, and we're unable to get the simplest of answers, and I'm not blaming individuals in this room, but I think we should be more prepared when you're coming to public accounts to answer some of the simplest of questions. And it's troubling to me that my first 6 questions that I put toward this committee, I can't get an answer, and we have to wait and wait and wait to get these responses. But I'll continue on. Dr. Link, I attended the press conference with Dr. Link and Dr. Strang. He said, and I quote, at historic levels, that the IWK emergency room is at historic levels. I have never seen before in my career here since 1990 as a young pediatrician. So he was pretty blunt about the current situation at the IWK, and essentially saying that unless you're, I shouldn't say essentially saying that unless your children are in acute or emergency care, extreme emergency care, that please don't come to the IWK. Is that acceptable health care service? And Ms. Lagassé, sorry if I pronounce it wrong, you said, and I quote, the way we've always done things is not working. It's time for change. So over the last year, what kind of change has happened where Dr. Link has said the IWK is the worst he's ever seen?
Deputy Lagassé.
That's okay. Thank you, Madam Chair. So I think there are a couple of things that I can respond to on behalf of our colleagues at the IWK. The first thing there in relation to the ED redevelopment project is currently underway, has started now at the IWK from an infrastructure perspective. That is new. Also in response to the very high volumes at the IWK over the last little while, again, from a system response perspective, we put the mobile unit out for 2 weekends in a row. Last weekend, most recently, it was out at Cobequid, and information has gone out through IWK networks that people can access care through the mobile unit. So that is new. That's helping to relieve pressure off of the emergency department. Our colleagues at the IWK are also looking at, as I said in my opening remarks as well, when someone is triaged, a determination is made as to what level of care they require. And so they're looking at and they're instituting a new clinic for more primary care like requirements once a patient has been triaged at the IWK, and they will set up a separate clinic area in the IWK to move those patients into a different area and to get them the care, the level of care that they need that might not be needed to be done right in the emergency room. So those are examples of things that are being done currently at the IWK that are new and different.
Mr. McGuire?
Well, I appreciate the response. Quite frankly, Dr. Link is on the ground and has said it's the worst it's ever been. So those were his words, not mine. It's the worst it's ever been. So the question is what are you doing to alleviate that? He actually said that before the press conference, he walked through the IWK, and he's never seen anything like that. So obviously, you're saying going forward, these are the things that we're doing. I'm asking what have you done, what has been done over the last year to prevent the current situation that we're in now?
Deputy Lagassé?
All of the items that I've spoken to already have been in planning over the last year, and there's been a number of different things that have been taken. They're also looking at increasing scopes of practice. As with all of our areas within the system, we're looking at recruiting and retaining as much as we can. There's been reassignment of individuals where they can within the facility to look after this. But we've been planning a whole bunch of different things to provide people with care that isn't needed in the emergency department, is what I would say.
Mr. McGuire?
The words you're using are planning and looking at. Those are future tense words. That's what you said. We're planning and we're looking at. Again, I will say that the head of, Dr. Link said that this is the worst it's ever been. We've just gone through years of COVID. We knew that the impact that it had on the system. So we had years to plan. We have one of the worst, if not the worst, influenza season coming up. We have very limited access to, no matter what government wants to say, we have very limited access to vaccines. If you go online and you try to book a vaccine, I was told to go to Guysborough. That's where I was told to go with my 3 kids. I've had people from my community tell me they had to go to Cape Breton. They were told to go to Yarmouth and Lunenburg and all these areas. Just because somebody is told that they can go tomorrow to Lunenburg is not access. So again, I will say, what was done over the last year to prepare for the current season, and why is it not working?
Deputy Lagassé.
Thank you, Madam Chair. I think when I answered your earlier question, Mr. McGuire, you asked what we had been doing over the last year. And so, as I said, we've been planning and implementing over the last year the items that I have already outlined for you. And I can tell you that our colleagues at the IWK and across the system at the NSH every day are looking at new things that they can do, and they're shifting where they can. But one of the limitations that we do have is human resources. We know that is a limitation, and then that's one thing that we are working very hard at from a recruitment perspective. But that is one thing that we cannot immediately produce. But there are a number of different things that we have done to try to provide more primary care access for individuals so they don't have to seek that at the emergency department.
Mr. McGuire?
Well, I appreciate the response in your opening statement. You contradicted that by saying this is simply not about adding more staff. That's what you said. You said this is simply not about adding more staff, and you just said that this is a human resource issue. So what I'm asking you is, how come we're in the current situation we are right now at the IBUK? What happened to put us in the current situation where Dr. Link said this is the worst he's ever seen? I just need a simple answer. Like, where did things go sideways, or where did things go wrong that we're in? And this isn't about the people that are working on the ground. I know a lot of people that are working at the IWK and in the system that are working their tails off. You know, the planning and the management of this is extremely important. So what would you change, and what do you think was done right, and we'll say what was done wrong? More importantly, what was done wrong to put us in the current situation at the IWK?
Ms. MacGibbon?
Thank you, Mr. McGuire. I just want to add to what the deputy has already provided. I think when you say what has gone wrong or what did we do to not prepare, I think what's the most important to remember is that what we're facing here in Nova Scotia is exactly what every other province in this country is facing. Children's hospitals across the country are connecting like they never have to talk about strategies to deal with the current surge that they're seeing. And it's at a time, as the deputy said, that we've seen a scarcity of human resources like never before. So the challenges on healthcare in general across every jurisdiction in this country are significant. As she's mentioned, we've been partnering in ways that we haven't in the past to ensure we're as collaborative and innovative as possible in supporting the demands of the system and the strains that we have on our workforce. So it's all of those factors that are colliding, so to speak, in our environment and every other environment in healthcare across Canada. And so I think another benefit that we have had in the past year is talking through with our colleagues in other provinces, as well as much as we can with every partner in Nova Scotia, to talk about the strategies that we can deploy to support and respond as best we possibly can. But I don't believe anything in Nova Scotia is different than what we are seeing everywhere else in Canada right now, unfortunately.
Mr. McGuire?
Well, I appreciate that. This was a government that was elected on healthcare and spent a historical amount of money on healthcare. Respectfully, I'm not, I don't mean to be obtuse, but I'm not really concerned about Ontario or New Brunswick or PEI or those other provinces or territories. What I am concerned about is that I had a constituent whose son broke his arm, and they were there for 14 hours, and he now has nerve damage because he wasn't seen. And so these are issues that parents are facing now. When you talk to parents and people that need to go to the emergency room or go to the IWK emergency, and you ask them, a lot of times they're not going because they know they're not going to get the care and the timely care. And this has nothing to do with the people on the ground. They're working their butts off. And so surely over the last year, there must have been issues that could have been improved on, and that's all I'm asking. Like, we're in this situation now, and I'm asking where could the health Department of Health improved on so that we're not in this situation? We have a 10% uptake in the vaccine, for influenza vaccine. That was from Dr. Strang, the lowest it's ever been. We have a premiers in the past and MLAs in the past have promoted get your vaccine. If you go on the Premier's Twitter account and social media, it's nowhere to be seen. It's nowhere to be seen. We've had rollouts from communication in local papers, in local media, and online encouraging people to get vaccines. We're not seeing that this year. We had probably one of the most important healthcare press conferences of the year, probably the most important. And again, Premier nowhere to be seen. So and it's important when we need the leaders of these provinces to step up. So whose idea has it been to not do a full communication rollout on getting your vaccine? And I mean, people can say, I can see some confusing looks, but the truth is if you go on social media, nobody's seeing it. You ask people, is there advertisements? We're not seeing the level of communication we've seen in the past. And that's extremely important because I think people they're a little vaccine wary right now because over the last few years, but it's extremely important that they get this influenza vaccine. And we heard from the healthcare professionals at the IWK and the emergency room that this is going to have a massive impact on our emergency room. And this could be one of the worst influenza seasons we've ever had. So whose idea has it been not to have a full rollout like we've had in the past? And why don't we have it?
Before we go to Deputy Lagassé, Mr. McGuire, there's 2 minutes left in your time. Deputy Lagassé.
Thank you, Madam Chair. As with anything we do, we always look at our strategies. I had a discussion with Dr. Strang just yesterday, talking about communication and other efforts that we might be able to make, him himself being made available again for media to talk about the vaccine uptake and rollout. And so we're always reviewing our communication strategies to make sure that we are reaching the broadest audiences. And as I've said, Dr. Strang and I had a conversation as recently as yesterday to ensure that we are making the broadest reach and getting message out to people as much as we can.
Mr. McGuire?
And I appreciate the answer, but we're in the middle of influenza season. Do you not think it's too late now or it's a little too late? Should we not have been doing this before flu season started?
Mr. McGuire. Sorry. Deputy Lagassé.
When vaccines were originally available, we would have had our communication program started at that time and ongoing. So we have been having ongoing communication about it, not the communication that you've been talking about, press conferences and such, but there has been ongoing communication to ensure that Nova Scotians know the vaccine is available.
Mr. McGuire, you have 35 seconds left.
Quick question. When was the vaccine first made available? What date?
I would have to confirm exactly, but I'm pretty sure.
Sorry, Deputy Lagassé, sorry.
Sorry, Madam Chair. I would have to confirm, but I'm pretty sure that it was near the end of September. I'm pretty sure that the first appointments were made available for booking they started being available to book for a week or two out at the end of September. I think, but I would have to confirm.
Mr. McGuire?
And so we've had months to roll a communication plan out, and yet here we are. And
Order. The time for the Liberal questioning has elapsed. Ms. LeBlanc?
Thank you very much. I just wanted to make a couple of comments on things that I've heard in the last 20 minutes before I ask my prepared questions. But, I want to say I'm glad to hear the deputy say that there's an acknowledgement of things needing to change. I know that there is work going on. And I will be acknowledging all of the things you said in your opening comments. I'm going to ask some specific questions about emergency care. I have to just echo my colleague's disappointment about the answers, those sort of quick snappers, short snapper answers. It would be great to be able to get those numbers quickly. And I'm wondering in general, like a system-wide thing, we do get published numbers on a number of things every month. But I'm wondering in terms of ER numbers, like if there is a way to start seeing those numbers more quickly and those detailed things about how many people show up, how many people leave, how many people, just how many people are getting treated and what the wait times are. And I also just want to say quickly about the IWK. I was at that press conference too with Dr. Link and Dr. Strang. It was deeply concerning, especially, a number of us have, and of course we represent folks with young kids, and But I'm wondering about the clinic, like the off, whatever it's called, that like sort of other room where people who aren't super acute go into to get treated. Wondering if there's a plan for that to stay. You know, like in terms of, we learn things from crises, and I'm wondering if there is any thought that that is just a stopgap or just a measure that is being taken for this crisis, or will we look at, you know, having that all the time? Different triage based.
Deputy Lagassé.
Thank you, Madam Chair. Right now, it's starting for a 12-week trial period, and the idea is that it would be open, or they would have that option during the peak hours when they're seeing the highest volumes coming through the emergency department, which right now is between approximately 5 p.m. and 11 p.m. That's usually their peak time that they would have, so that's why they would institute this particular option during those periods. The goal is for it to run 7 days a week. They're getting started there. I think later this week actually is when they hope to actually have it open. 7 days a week will depend on staffing. Is really, that will be the only limitation, is to if they can have enough staff to run it 7 days a week. So 12-week trial period, but as with everything we do, if the need is still there and it's working as they hope that it would, then I would say that there would be an opportunity for it to continue.
Ms. LeBlanc?
Thanks. And I just want to say also about the kids booster thing. So I find it deeply concerning that it is very difficult in the HRM, at least in Central Zone, to get a child's booster shot right now for COVID. So I have been trying for a month, and my colleague, the leader of the NDP, has been trying, and we would sit there in the legislature and try to book booster shots for our kids, and it was virtually impossible. So for a month now, we have been communicating with the Minister of Health's special advisor, who literally said, thanks for letting us know about this issue, which is surprising, right? Like, one would think that the department knows about this issue. Then at the conference the other day, Dr. Strang said there were more boosters added. I literally just checked this moment, plugged my address in, and there's one appointment today, this afternoon, on Quinpool Road, and the next available appointment is December 23rd. So, and then the other pharmacies that are in sort of our locations, the next available is December 23rd. So what is happening? I want my kids to be boosted. I want them to be fully protected. I want them to stay out of the ER. It's impossible if we don't have those options. And I know that Dr. Strang's answer the other day was, well, you can drive to Tantallon, or you can drive to Kentville or whatever. And it's like, well, fine, I can do that, but most people can't take time off to get their kids boosted an hour away. So anyone got a comment on that?
Deputy Lagassé.
Thank you for the question. I've asked our public health colleagues if they can send information, hopefully while we're in here today. Every time that I check on it, I've been told that there are sufficient appointments. You're clearly telling me that there aren't, and so I'm following up on that as we speak.
Great. Thank you.
Ms. LeBlanc, and thank you, Deputy, for actioning that while we're sitting here. Ms. LeBlanc.
Great, thank you. So, you know, in terms of the continuum of care and the flow of care, we know that there is primary care. We know that there's EHS services and all of the issues with paramedics. And then there's, of course, the acute care bed issue. And then there's, of course, the long-term care bed issue. And it seems like we need to work on all of those things. But today I want to ask some really specific emergency department questions. So to Deputy Lagassé, in April of this year, it was reported that $500,000 was being spent on virtual care platforms with Maple. I'm wondering if you can provide an updated figure on what we're spending with Maple, and what portion of it is for the Virtual Emergency Nova Scotia program.
That sounds almost soothing.
Deputy Lagassé.
Yeah, I'm going to ask my colleagues at NSH if they know specifically on the virtual ED part of it, but I do not know how much of that funding. I'd have to look into it, how much of that $500,000 was specifically for that program.
Ms. LeBlanc?
Yeah, and the other question is the $500,000 still the same number, or has it changed? So if we can get those answers. So is there a difference between the $500,000 first amount that was reported in April, and what portion is for virtual care? And then, my next question is, what is the average cost of an ER visit using Maple? And is the department or anyone able to provide a cost comparison between an in-person appointment at an ER, like an in-person visit and a virtual care emergency appointment. This is important information because we need to know, A, are we, like, you know, is it a cost benefit to have virtual emergency, or is it cheaper to have in-person emergency, or are we saving tons of money with having virtual appointments? I want to get at this question. So that would be really important for us to have those answers ASAP. I'm assuming no one can give me those answers right now, but maybe I'm wrong.
Deputy Lagassé?
I can't provide that level of information, but I'd like to say to you that, you know, the reason for introducing the virtual in the ED is to help provide better access, right? So there will be a cost to some of that. So I think I understand what your question is about understanding the cost differential, but really it is another way to provide better access to Nova Scotians to have that service available in the ED so that some people don't have to wait as long for their service. I don't know, Eileen, do you want to add anything to that?
Dr. Munroe?
Thank you, Madam Chair. I can add a little bit to the value question, although I can't give you the dollars and cents. The value to the patient is that they have the ability to be taken out of what is an unacceptably long line for care some days, and if they consent to being seen in a virtual platform, I, as a virtual emergency provider, can already start talking to them about their concern that brought them there, formulating a differential diagnosis. I can order upfront treatment. So if you've come in and you've got a fever and you're nauseated and the wait to see a physician in person is going to be 6 hours and you agree to see me, while I'm sorting through my plan of care for you, I can have my virtual care assistant, who's an in-person in the department, start your treatment, start your investigations. I can order your labs, I can review your cardiogram, I can watch my physician's assistant perform your exam and glean from that the signs of something more sinister or something that I can be reassuring to the patient about. And we can complete that visit in less time than it would have taken them to sit in an ED waiting room waiting for care. I can also serve patients in multiple waiting rooms. Last week I was able to work between Colchester patients and Yarmouth patients. In a 4-hour period, I believe I saw between 12 and 14 patients, satisfactorily resolved all of their complaints, completed WCB documentation, designed outpatient follow-up plans of care, sent prescriptions to pharmacies, and I felt they were satisfied. I also provided them with appropriate return precautions, come back if the following things happen. If at any point in time during this experience with the patient, I felt they needed to be seen in person in the moment by my colleague, it's simply a matter of a phone call. And by doing that, I did save 12 patients an extra wait in the emergency department. That potentially allowed 12 more patients to come into the care footprint that they needed. It also has the potential to extend the shelf life of the emergency clinician. The job's challenging, it involves shifts. I'm not getting any younger. I can do a blend of work that enables me to stay in the profession longer. If I was a physician in the last 5 years of my career and given the opportunity to provide appropriate care through a virtual format, in addition to maybe a reduction in shifts, I can still contribute as opposed to stepping completely away. And when we are so pressured for health human resources, any strategy or innovation that extends the shelf life of any provider in our system has far more value than just dollars and cents.
Thank you. Ms. LeBlanc.
Thank you. No, I am not suggesting that there is no value in virtual care or virtual care emergency. 100%, I think that there is a place for it. But this is a public accounts committee where we're studying how the money of the province is being spent. And so I think to ask the question, to see cost-benefit analysis or just the difference is very important for us. I'm not here to say virtual care is not a good program. I'm here to ask how much it costs. And what you're saying suggests to me that it's highly efficient, and that's great. But we need to have those. We need to see that so that we know how to move forward or to criticize or not criticize or whatever. But thank you for your work, because certainly I would I'm a kind of person who would definitely take Doctor up on that if I was in the emergency room. Moving on, though, at a health committee meeting earlier this year, representation from the Office of Healthcare Professional Recruitment stated that the current incentive programs that were for healthcare recruitment, so people, did not address emergency room physicians, though there was an interest, quote unquote. So I'm wondering if there is any updates on that. Is the government creating financial incentives specific to emergency medicine physicians? And let's just say emergency room nurses and nurse practitioners as well? And are there any out-of-province recruited physicians now working in emergency rooms? So there's 3 questions there. Updates on the interest in the program. Are there new incentives for emergency room physicians? And are there any newly recruited physicians working in emergency departments in Nova Scotia?
And I think we have seen Ms. McCormick approach the microphone, so I'm thinking she might have some answers there. So Ms. McCormick.
Thank you, Madam Chair. I'm going to start with the nursing incentive component. So certainly when we are recruiting to the emergency department and all nursing positions within Nova Scotia Health, if we are having difficulty filling a position, we do have the ability to provide incentives upon hiring an external applicant, which can include incentive return and return of service for that applicant, but also support for relocation allowance if they are requiring that to come to the province. So certainly for nursing, as well as pharmacists and other individuals that support emergency care, that option is available. And as we go out across the country to recruit or are seeking applicants externally, that is something that we can apply when it's a hard-to-fill position.
And anything about physicians?
I will defer that comment to one of my colleagues.
Ms. Penney?
Oh, no, I'll take that one.
Okay. Saw the glasses go on, so I thought you were getting ready to talk. Right. Deputy Lagassé.
Yeah, so the physician incentives that the new ones are still in place. So it's the up to $125,000 is the primary care incentive, and then there's also the specialist incentive that is the same amount for outside of central zone. Those are the incentives. There has been a minor change, I know, in the program related to some doctors that do provide some ED coverage, but I would have to get the exact detail for you on that.
Ms. LeBlanc?
Okay, yeah, so the question is there a special incentive for doctors in emergency departments, emergency room physicians, and are there any newly recruited physicians working in emergency departments? So if you can get that information, that would be great. So, you know, when I say the newly recruited, I mean, remember the press conference with the minister when she was like 68 doctors or whatever? Are any of those working in emergency rooms? I forget the exact number.
Okay, so we will add that to the list of questions that we would like to have answered by the, and I do think that we might have some answers from Ms. McCormick again. Ms. McCormick?
Thank you. I was able to source some of the questions asked earlier, so I wanted to provide an update on those.
Yeah, because this is her time.
Okay,
so.
thank you. I do have some of those numbers available if you would like me to address them at a later time.
Mr. McGuire, so we'll put that in Mr. McGuire's time.
Okay, thank you very much.
Maybe. So, Ms. LeBlanc.
Great. So last week, the media reported on the province's recent expenses for travel nurses in long-term care and acute care. There was a CBC article, and I also have a link to the job posting. But the Department of Seniors and Long-Term Care is reportedly spending $18.4 million to hire out-of-province agency nurses to fill in vacancies. I'm wondering if you can advise if the department is also hiring travel nurses for hospital and specifically emergency medicine positions. So I'm not sure if that's what you're talking about, Ms. McCormick, is it? McCormick? And if that is the case, can you talk about the cost? Yeah, thank you.
Ms. McCormick?
Thank you for the question. So Nova Scotia Health does hire travel nurses or agency staff at times. We look to hire agency staff or travel nurses after we have exhausted the internal options available to us, including offering overtime and extra shifts to our own staff. It does come at a cost, of course. We do use them in the emergency department as well as in other areas of our hospitals and services as needed. We did spend in 2022-23 year-to-date $11.4 million on travel nursing.
Ms. LeBlanc?
Great, thank you for that answer. A Google search for local emergency nurse positions shows that agencies are actively recruiting in the area for nurses to work outside of Nova Scotia. These nurses would be able to make nearly triple their wages by switching to agency work with added benefits of greater flexibility and autonomy. So how is Nova Scotia Health remaining competitive with those options to ensure nurse retention?
Ms. McCormick?
So retention is a very important topic within Nova Scotia Health, and we are talking with our staff and our frontline managers about how we address that in the best way. We know that travel nursing provides flexibility in schedule to those employees. It also provides a higher rate of pay. Those two items are very appealing to some nurses who wish to go into travel nursing. We are looking at a number of factors within Nova Scotia Health, such as scheduling flexibility around FTE, so whether somebody perhaps wants to work 80% of the time instead of 100% of the time to increase, their work-life balance. We're also working very hard to ensure that we can allow people to have their scheduled and planned breaks and vacations as requested. Those are some of the factors that we know really impact a nurse or a healthcare provider's ability to have that work-life balance. We're also regularly meeting with our teams to hear more from them about what will help them to be happy at work, including working to optimize scopes of practice and having the opportunity to try new areas of practice. So we certainly recognize that we don't want to lose staff to travel nursing, but for some, it's a career choice that they make for their own personal reasons.
Ms. LeBlanc, you have just over 2 minutes.
Okay, well, I'll just stay on that then, because it seems to me if you're spending $11.4 million on bringing travel nurses in, and then but then there's a whole bunch of people that are going out because of does it not make sense to spend the $11.4 million on making it better for homegrown local nurses to be happy in their jobs and not have to leave? Obviously, we want people to stay in Nova Scotia. Has there been any analysis of that done? Happy to hear that you're looking at flexibility, but also, wages is an issue, right? And especially with cost of living the way it is, we need to make sure we're properly compensating our healthcare professionals. So any comments on that?
Ms. McCormick?
Thank you. Certainly, there is no, we are not approaching retention of staff with thinking of the budget as a limiting factor. If there are adjustments that we can make around overtime, offering flexibility in schedules, those types of things, and there's a cost to that, that is not a prohibiting factor for us. We're taking everything into account. We invest routinely to make adjustments to the FTEs available to individuals over and above what our planned budget amount is. If we have somebody who's working, for example, 60%, and they were to come to their manager and say, I need more planned and secured hours to be able to stay here because I need more income, we have the flexibility in the organization to evaluate that and increase their guaranteed hours so that we can retain them. So I guess in short, we're doing everything that we can, including being flexible with how we're spending those dollars to ensure that we're keeping people local here.
Ms. LeBlanc, you have 30 seconds.
Has there been any consideration of providing childcare on site for nursing staff and hospitals?
Ms. McCormick?
So we actually have had a number of conversations about that and the value that that would bring for shift workers in particular, and in communities where childcare is very scarce. So just as recent as last week, I had a discussion with my staff in a particular hospital in my zone about the value that would bring, and we're exploring it.
Thank you. And the time for the NDP questioning has elapsed. We now move on to the PC Caucus. Mr. McDonald.
Thank you, Madam Chair. I just wanted to clarify a couple things before I ask. So, Deputy Lagassé, did I say it right? Yes. Okay, thank you. You keep saying ED, so that's what I would call an ER, correct? It's just a different terminology. I mean, as for the chair's point, the millions of Nova Scotians that are watching us, hey, on Ledge TV. I need you to introduce her so she.
Deputy Lagassé.
Yes, that is correct. That we tend to use. I think there's a subtle difference, but we do tend to use the terms interchangeably, ER and ED.
Mr. McDonald.
Thank you. And just also, in your opening, you mentioned more staffing. What I don't want to speak for you, but what you mean is no additional, not the point that we have a deficit today. It's not we need to add 5,000 nurses on top of the current nurses. We need to fill the positions we still have open. I just want to clarify that with you.
Deputy Lagassé.
That is correct, that unfortunately, right now, we have very high vacancy rates across all of our zones and in all of our facilities.
Mr. McDonald.
I should know better.
We all
Thank you,
do.
Madam Chair.
We all do.
And the last, before I get into my questions, is there was a comment on what we could have done in the last year. I would believe that everybody around here would realize the best time to plant a tree was 20 years ago. The best time to deal with climate was 20 years ago. The best to actually deal with this would have been planted 20 years ago. So you did say that you're working more collaboratively with other hospitals to figure out so you're not reinventing the wheel. Is that a correct assumption that, like, in a way, because everybody's having it, everybody is now sharing, well, this is how we're doing it, this is how we're doing it, so that we're getting, you know, again, you're not having to reinvent the wheel.
Deputy Lagassé.
Yes, that is correct. I know that, and my colleagues can probably speak more specifically related to the hospital and health authority system, but I can tell you at the government department level that we have very interconnected federal, provincial, territorial groups that meet. So Ms. Penney would participate in various groups related to policy areas that the department is responsible for. But I do know from my meetings with the CEOs of NSHA and IWK as well, they are very connected with their colleagues across the country in different facilities.
Mr. McDonald?
Thank you. And Madam Chair, just so you're aware, I emailed the clerk the list. There's a dashboard that will, I think, might get some of the information. Won't get all. So I did email the clerk, which then the clerk emails that out to all the members of PAC, so they have them. So the dashboard is there for some. It won't give all. It doesn't. I can't find the IWK numbers, but I am going to get to my questions now. Sorry. So last month there was an announcement regarding a new project, a new pilot project to place physician assistants in one emergency department in Central and in Western. Can you tell me more about the physician assistants and how they're going to complement the emergency department? And I'll let you decide who I'm not going to pick.
Dr. Munroe?
Thank you, Madam Chair. I can take a stab at that. I work in Northern Zone, so I don't have any personal experience with physician assistants, but I have been in conversation with my colleague Todd Howlett, who's instrumental in that initiative. What we're looking for is any opportunity to increase the scope of practice of any individual who can assist providing ED care. So if there are certain tasks that only I can do and I'm given the time to focus on those, it frees me up from other, makes me more efficient. So a physician's assistant essentially is a physician's extender. There is a large subset of emerge work that could be done in conjunction with a physician, and the faster we get the work done, the faster we get the patients to the appropriate place for recovery, whether it's home or in the inpatient units, or transferred onto a higher level of care if you're in a smaller site. Anyone that can contribute to this is of value. So the physician assistant is one expanded area. We've also looked at how we're using paramedics, advanced care and primary care paramedics in the emergency department. We have introduced LPN skill set to the emergency department. We've taken steps to ensure that we've got all of the support services adequately resourced as well, including creating some additional positions so that we've got everybody kind of shouldering the load.
Mr. McDonald?
Thank you, Madam Chair. So you raise a good point. So you're in Northern Zone. Are we looking at rolling this out more to the other zones and different ones? And is it kind of a timeline as to after this? And I'm not sure who's going to take that answer. So,
Ms. MacGibbon?
Yes, thank you for your question. That's exactly what we're doing. We're looking at the best settings across the system, but trialing a different approach pretty much across all 4 zones to understand where we'll get the most value. We've identified the areas where there is huge potential to, as Dr. Munroe mentioned, extend the scope, or introduce the scope of a physician assistant to support our team in ways that we haven't in the past. So, for instance, in Central Zone, we've been working with physician assistants within orthopedics, and it's been very successful. So that's more in the acute care longitudinally across the system in terms of pre-surgery and after surgery, and then into clinic environments. And then now looking at, we've had physician assistants at Cobequid. That's been a very successful experience for the system and for the teams working there. Now looking at the Dartmouth General, and as Dr. Munroe mentioned, within Northern, and then all of our zones having opportunity to trial and understand where physician assistants can provide value.
Mr. McDonald?
Sounds good. So, and I'm going to say understaffing, but I guess it's vacancies is a proper way to say it. So to address vacancies in the ER, we agree more health professionals are needed. Can you discuss what are being taken to retain more health professionals who work at ERs? You know, for example, you know, the offering all the nurses a job. Like, what else are we doing? Or are you doing, I should say, it's not me.
Ms. MacGibbon?
Thank you. Yes, and my colleague, Ms. McCormick, already mentioned a number of things we're doing from a comprehensive understanding what it is that our staff really want in the work setting, and understanding why it is they're motivated to look at opportunities with travel nursing agencies. And I think she outlined very well that it's flexibility and it is more lucrative. However, to the points made earlier by Ms. LeBlanc, there's opportunity for us to do things differently with flexibility and scheduling. Our staff, I think healthcare as an industry has been incredibly impacted by COVID. We all know that, and folks are tired. And so if there was ever a time for us to look at models of care and skill mix within teams, it certainly is now, because we have a huge openness by our teams to think differently about how they work and how they work together. So for us right now, it's to understand what it is they want in the environment, so that if they're choosing to leave, how can we change the circumstances of the conditions of employment to make it so that they make the choice to stay with us. And as Ms. McCormick mentioned, sometimes it's as simple as saying maybe your 1.0 full-time position, if it was 0.75 or 0.8, would give you the flex to say, if you don't want to work that fifth shift, you don't have to. It's up to you, or you can pick it up. And I think that's the flexibility that they've been afforded by way of these external travel agency-like environments. They can pick and choose, so we have to be more open to giving them opportunities to think differently about how we schedule. So that's certainly a major area of focus for us.
Mr. McDonald?
Ms.
Ms.
McCormick.
McCormick. Yeah.
I think another important support that we're offering is through our interprofessional practice and learning team. So we have a very sophisticated and comprehensive training and learning support network within Nova Scotia Health, where we have practice leaders and clinical nurse educators and training programs available to staff, both to enhance their competency as they're entering the emergency department, if they were a newer nurse, for example, but also to continue to advance skills of those that are perhaps a little bit later in their career. This also allows them the opportunity to offer mentorship to new graduates or to new nurses coming into the emergency department as well. So as you move into the later years of your career, sometimes you get that real joy and passion back by teaching others. So we have that available. Also, the team-based approach in emergency care is very important. We have examples of pharmacists working, side by side with the nursing team to do that medication management and offer their expertise. As Dr. Munroe said, if we can free up the nurses and we can free up the doctors to do the important work that only they can do by building the team out around them, that's very key. Things like ensuring we have ward clerks around the clock, environmental services on every hour, that you have aides that can get the supplies so that the nursing staff and the physician staff's time is completely optimized. So that does contribute to a better overall work environment for that team.
Okay, Mr. McDonald, you have 10 minutes left. Mr. McDonald.
Okay. Thank you very much for that. I mean, and I know a lot of nurses. My fiance is a nurse at the IWK, and I know those things, I'm sure all of them are enjoying, that there's getting into it. I just want to go back to, you mentioned going from a 1.0 to 0.7 on flexibility. So is that something that's new, or is that something that has been around for a bit, or is it we're trying to find people's work-life balance? I'm just looking at Ms. MacGibbon, but I'm not sure if she's answering
Ms.
or not.
MacGibbon. Yes.
Thank you. That's a good question. I think if the position existed as part of the complement of staffing, I think staff knew that then they could seek or pursue those kinds of reduced hours. What we want to do is be more open about the flexibility we want to have with maybe taking a 1.0 position and changing it to meet what might be the needs of the team, to say, you know, do we have people that would be more interested in working less hours? So how do we create a complement of staff that would support the needs of the area, but also give the staff the types of arrangements with us, with hours that work better for them and keep them employed with us versus leaving to gain that somewhere else. So I think it's always been a potential, but now we're trying to be much more, increase the awareness for the potential for us to move in that direction more than we have in the past.
Mr. McDonald?
Thank you. So I just get two more questions on that, and then I'll turn it over to MLA from Kings West. But so I look at the opposite, which is a 0.7 going to a 1.0, because you mentioned one. And the second question, and I'll just get them both to you, is when nurses and physicians or whoever leave, do we do exit interviews to ensure we know this is why? So, and I shouldn't say we, you. I'm not in the unit. I'm not in. But does the department do exit interviews to get an idea of here's some things that they've identified when they left to actually improve it? I'm just.
Ms. MacGibbon?
Yeah, thank you. I think exit interviews were always in any industry a typical practice to understand the reasons for leaving. What we've shifted toward is stay interviews, to understand current state assessment information from our staff, to understand what's working and what might not be, so that we don't get to a place where we're having an exit interview because they've made a decision to leave. So stay interviews are actually more important and give us more of a understanding of the areas we may need to be augmenting or changing in any way to support a staff member choosing to stay with Nova Scotia Health versus finding something else.
Mr. McDonald?
Thank you. And I do have one last question, which I forgot, which is there's a new program called Patient Track, which provides emergency departments, staff with real-time access to patient information. Can you talk about how you got to the decision of what this will mean for healthcare workers who are using it? Oh,
Dr. Munroe.
So all the questions to you.
As an end user of Patient Track, I'm probably the best one to speak to that one. Actually, Patient Track came around in 2012 when the Colchester East Hants Health Centre first opened. It was one of our local IT individuals who recognized the days of the Sharpie and the whiteboard needed to be long behind us. So we've had it for about 10 years in that site. It's now rolled out across the regionals. What it does is it enables you in real time to see who are the patients in your department, who are the patients in your EHS hallway, who are the patients in your waiting room, what are their presenting complaints, and what is their triage score, so how sick are they. It also tells you how long they have been there. It tells you who the nurse assigned to their care is, or the paramedic, or the other care provider, and who the physician is. So when I come in and start my shift, the first thing I do is I look at the board, I look in the waiting room, I try to strategize how I'm going to approach my shift so I can get to the sickest first. So when I've started my work and I've ordered investigations or treatments, the nurses then have a mechanism to flag when an investigation has returned, whether they need new orders or if they need me for something. We can also put in all the necessary symbols that tell you if a patient has infection control issues, very important in the triple threat of RSV, COVID, and the flu.
It's my timer, just so you know. Sorry for no, you haven't done 20 minutes. I was trying to change it so it wouldn't be so annoying and interrupty, the one I had, so my apologies. Please continue, Dr. Munroe.
You know, the long and the short of it is Patient Track is a huge improvement. It's very helpful to me and all the providers I work with. Sometimes when we do have nurses that come from a travel agency nursing, they may not even know who Dr. Munroe is. So it enables them to find the physician faster, track me down if I haven't noticed, that in 10 minutes, if they've wanted me, they flicked it to reassess, it starts to blink. So if you're someone that has a limited attention span, lights blinking at you, that tends to grab it. So this has been spread across all of the regional sites. It's a bridging to the OPOR, and it's very, very useful in the moment to try and gain any efficiencies within the department.
Thank you. Mr. Palmer.
Thank you, Madam Chair. Thank you all for being here. Great conversation to have around government investment and how we're helping to alleviate pressures on ERs. I represent a constituency in Kings West where many of my constituents from Aylesford, Kingston, Greenwood would access Soldiers Memorial Hospital in Middleton. And recently, there was a $1.7 million investment in substance abuse and addictions recovery support centers. And one of those centers recently opened at Soldier Memorial. And so I guess my question would be to the deputy or anybody who'd like to answer. Could you speak about how this investment and how the new centers like the one in Soldier Memorial will benefit emergency departments and help support care in those departments, and how those will benefit the staff there? Anybody?
Deputy Lagassé?
I'm actually going to ask Ms. McCormick to take that question, Mr. Palmer, because she's also the Vice President responsible for addictions and mental health.
Ms. McCormick?
Thank you very much. So the recovery support hubs are a new innovative model to provide addictions medicine care to individuals who need that support. It combines a variety of different techniques and strategies that bridge the continuum of care for that individual, providing them the right level of care for their need. So it could be coming in during a day visit and having support from groups and clinical therapists, as well as pharmaceutical adjustments. And in some cases, they do have the availability for an overnight stay if they do need that as well. There are a number of these recovery support centers across the province, and they are continuing to scale up and provide support. It's really about matching the need of the care to the patient. It's a leading evidence-based practice, and we're really excited to have that growing in the province.
Mr. Palmer, you have 2.5 minutes left.
Okay. I'm not sure who this next question would be for, but I guess Mr. Coates or the deputy. Ensuring people have the care they need before they end up in a situation where they need to get to the ER is very important as well. Can you discuss what the government's been doing, any investments to address health promotion, and maybe ensuring people are more proactive and, as opposed to reactive as an approach to health? So wondering if there's anybody that could speak to that.
Ms. Penney?
I'll take it.
Oh, Deputy Lagassé.
Thank you for the question. So our public health folks, both in the department and at NSH, work very closely together on all promotion problems. In Action for Health, Solution 6 is about really our community wellness solution. So through Action for Health and that solution, there will be considerable work being done on community wellness frameworks, asset mapping in communities to determine what is already out there, working with community-based organizations on granting and other programs to help promote for health promotion. So a number of different ways that we're going to be working through Action for Health to promote on health promotion.
Mr. Palmer?
Anytime we have, just a question. I represent a community with CFB Greenwood on a base there, and just wondering, is there collaboration or communication with health practitioners in areas like that to potentially work with our system to any help at all?
Deputy Lagassé?
Yeah, Eric?
Oh, okay. 40 seconds. Mr. Coates.
Thanks for the question. We do partner with Department of Defense. So the Cobequid example with the physician assistants that Ms. MacGibbon mentioned, they were employees of Department of Defense, and it was actually an initiative to help keep their skills up when they're not deployed and actively seeing patients. So it gives them the opportunity to stay fresh and current and see patients, and as well as for years in emergency departments, at least in Central Zone where I'm familiar, we've had nursing staff come support our teams, and they're usually very skilled, and it's a very strong partnership that we appreciate.
Order. Thank you. The time for the PC questioning has elapsed. We'll now move on to the second round. Each caucus will have 5 minutes. Mr. McGuire, you have to 10:19.
Okay, and so with the limited time, again, I asked just for direct answers. So how many people have left an ER without being seen this year?
Deputy Lagassé?
So the last statistics that I have were for 21-22, And in that year, there were 43,142 patients who visited EDs that left without being seen. And there were a total of 536,666 visits in total to EDs across the province that same year, so approximately 8% leaving without being seen.
Mr. McGuire?
Okay. We talked about, we've talked a lot here today about working with other provinces and across Canada. So we know in other provinces and across Canada, the high-dose flu shots for seniors are covered, but Nova Scotia, they're not. Why?
Deputy Lagassé?
Yeah, that's an item that's currently under consideration. They are covered for seniors who live in congregate living settings, so it's not that it's not at all covered. It is covered in that, but it's just not covered out in the community at this point in time.
Mr. McGuire?
Again, another question about things that are happening across Canada but are not happening here in Nova Scotia. We know that, first of all, how many unvaccinated healthcare workers are not working right now? Why are other provinces and the federal government allowing them back to work and Nova Scotia is not?
Deputy Lagassé? Deputy Lagassé?
I know out of the approximately 25,000 employees that NSH would have at NSH alone, it's a very small number. I do not have that exact number here. And I can tell you that the policy is not currently under reconsideration, that the policy stands that unvaccinated healthcare workers are not. And it's not just healthcare workers, it's in other high-risk settings as well. The policy applies to other high-risk settings.
Mr. McGuire?
When will we see the Bedeck ER reopen?
Deputy Lagassé? Oh,
I'll take it.
To Ms. McCormick? Ms. McCormick?
Sure. So I know from my colleague in the Eastern Zone that it's currently operating as the Urgent Treatment Center, and they're working as quickly as they can to operationally realign it to be back open as a full level 4 ED. And they're working quickly on that. The precise timeline is not known, but as soon as operationally feasible, it will be reopened as a level 4 emergency department.
Mr. McGuire? You have 2 minutes.
Yep. When can we see the full redevelopment of the QE2 hospital, which we know it will attract and recruit new doctors and new healthcare professionals? When can we expect that project to come back online, and when can we expect it to be completed?
Deputy Lagassé?
I know that our colleagues were here within the last couple of weeks to talk about that project, and today I can tell you that you can expect probably to get further information shortly, but I do not have a further update from the last time colleagues were here today.
Mr. McGuire, you have 1 minute.
Yep, thank you. And I want to thank all of you for being here today. I know some of these questions aren't the easiest, but I appreciate you being here to answer these questions. So I guess the last question I have is obviously the IWK situation is very pressing, and influenza season is here. We haven't yet reached the peak seasonal flu and respiratory season. How confident are you, because Dr. Link was not very confident and neither was Dr. Strang, that the system can handle more patients than is already there, and that it will be able to accommodate those people?
Ms. MacGibbon?
Yeah, thank you, Mr. McGuire. We're all concerned. I think across the system we're concerned because we're seeing unprecedented levels, as the deputy has mentioned, with respect to demands on the system. I will say that the IWK, and it's been mentioned earlier, and Nova Scotia Health have been extremely successful with recent clinics we've done to be responsive.
Order. Time for the Liberal questioning has elapsed. We'll now move on to the NDP for 5 minutes. Ms. Hanson?
Thank you. Thank you, Madam Chair. I just have a few points first before I get into my questions, but I want to say I'm really appreciative of each and every one of you here, especially we are in a crisis time with our healthcare, and I know that time is valuable, so I truly appreciate the work that you do and the folks that are on the ground doing that work. I also want to make a few points. First and foremost, I'm so glad that the government has taking on the idea, our idea of physician assistants. We've only been talking about this for 3 years, so truly grateful to see that that particular idea is now offsetting, you know, the wait times and as well doing the work that needs to be done to kind of alleviate some of those pressures. So appreciative of that. I also want to say that, you know, what I'm hearing, because I've been listening, is that like the government side is talking about their own investments, which we all know we have heard them many times in the House, and I'm really grateful that you guys were able to give us that information. But we do have that information, and we know that you guys are all working very hard to do that work. So it's really kind of, you know, interesting to hear that, because our focus is on healthcare and the emergency care right now. So one of my questions is, because I know, you know, with healthcare workers, most, if not all, are trained in crisis and pivoting to be able to adapt to that particular crisis. And so we know that this particular crisis is threefold now because of the viruses that are at play. But, you know, I'm wondering why it's taking us quite a bit of a time to really get to where we need to get to, considering the fact that we've just went through COVID and all these things. I'm not an expert, but I just wanted to bring that up because, you know, I understand that our healthcare workers are going through so much because they are tired and overworked. But I just wanted to make a point of that because this is a hard job. Healthcare, it by no stretch of the means is an easy job, but we need them. We need them here, which is why it's so important for us to talk about retention. So. A recent report from Statistics Canada found that 17.9% of all healthcare workers were intending to leave their current job in the next 3 years. This number is even higher among nurses, 1 in 4. So we talked about the encouragement and retention and the recruitment and such. And just by listening, when we talked about hiring travel nurses and the amount of money that we're putting out there for travel nurses, I'm wondering, and I heard working with flexible hours and matching, you know, the work-life balance. Are we matching those wages as well so that we can continue to keep these nurses and the other physicians here to make sure that we don't lose them because of other competitive wages?
Deputy Lagassé.
So I'm sure you're aware that the contract with the nurses is currently expired. So both the government and the nurses union are obviously clearly committed to the bargaining process, and we are open to new ways of doing things. Wages is one aspect of it, but we are also wanting to look at new ways of doing things and ensuring that we're meeting all of the things that my colleagues have spoken about today, and ensuring that we are meeting the, you know, what nurses really need to be able to keep them in the workforce. So wages being one part of it, but we think that there are a number of other things outside of collective bargaining that we may be able to do as well.
Ms. Hanson, you have a minute and a half.
Thank you. So last fall, the Premier reported that all nurses graduating from Nova Scotia universities and Nova Scotia Community College for the next 5 years will be offered a job in the province. Can you provide an update on how many 2022 graduates have now been offered a job in the province?
Ms. Penney?
So 2022 from a December perspective, so if you think about how nurses graduate in the province, they typically graduate in the spring and then they graduate again in the fall. And so I have the fall numbers with me today and can certainly get the spring numbers for you as well. But and the fall cohort is much smaller than the spring cohort. And so as it stands right now, in last year, all 40 graduates from St. FX in December of 2021 were offered and given jobs and were successful. And in December of 2022, just 11, but that was actually 80% of the class. Yeah, so smaller cohort numbers in the fall.
Ms. Hanson, you have 35 seconds.
That's people who accepted the jobs or people who were offered?
Okay. Yes, could you clarify
Ms.
that?
Hanson?
Accepted or offered?
Ms. Penney.
Both.
Ms. Hanson?
Okay, and Nova Scotia Health, and this could be to Ms. MacGibbon or Ms. McCormick, Nova Scotia Health has reportedly been offering signing bonuses for up to $10,000 to recruit healthcare workers. Can you report on the results of this project, and has there been any feedback from physicians on the amount of bonuses compared to other jurisdictions?
Ms. McCormick, you have 1 second. Oh, order, there we go.
That was good. That was good.
Okay, the time for the NDP questioning is elapsed. We will now go over to Mr. Taggart.
Thank you, Chair. I wish I had an hour. I just want to make a quick comment before I ask my question. Very thrilled to have the folks here from Northern Region. Unfortunately, I spent a significant amount of time in the emergency room at the Colchester Regional in the last month, and I need to say, as much as it's a frustrating experience for both those in the waiting room and those behind the curtain, so to speak, I watched this virtual care kind of thing roll out in the way it took patients out of the emergency room. So I just wanted to make that comment. But really, my question here is for Ms. McCormick. And so we all recognize, or at least I think we all recognize that one of the biggest challenges in packed emergency rooms is the challenge we face with respect to primary care physicians in the community, and that's very prevalent in rural Nova Scotia. So before being elected as an MLA, I was deeply involved with healthcare in my community, having served as chair of the West Colchester Medical Society. I'm very pleased to see some of the progress that has been made over the past year in my constituency. And I know a lot of work has been done, kind of most of it's not that visible, but is happening behind the scenes. And I'm wondering if Ms. McCormick can identify some of the changes we are seeing in the northern region, specifically how we are setting up our area for future success.
Ms. McCormick.
Thank you for the question. Investing in our primary health care system and our teams that provide primary care to individuals in our community is very important in the northern zone. We have been taking various approaches with feedback from the physicians and nurse practitioners and teams to build really new and innovative spaces where providers like to come into work, and so it's what's called a turnkey model. So the physician is able to come into a space and have their clinic provide the care without having to necessarily take on the setup of the building and the business aspect of it, but they really are focused in on that client care, patient care. Another very interesting and fruitful approach is what we have a hub and spoke model. So where there's a primary clinic in perhaps a more populated area that healthcare providers are based from. So the team is based from this hub where they provide care, and then they outreach to smaller communities that are perhaps more rural or have less of a demand. So they may go out for a day or two through the week with either the nurse practitioner or the physician or both to provide outreach. So we do that currently from Parsboro to Advocate Harbour right now. We're looking at doing that in a number of other areas in the zone to make sure that we have the right resources in the right place and really are maximizing the amount of patients and families that we can see on any given day. So that hub and spoke model, team model, and collaborative care practices that are ready to go for those physicians that want to come are some of the things we're doing.
Mr. Taggart?
I wonder if you were able to expand more on that collaborative care model and how that appears to will be successful in rural Nova Scotia, please.
Ms. McCormick?
So primary care collaborative teams are an approach to care that includes physicians, nurse practitioners, family practice nurses, sometimes dietitians, social workers, physiotherapists, and other providers. And so what this does is wrap a team of professionals around the patient and family to really ensure that their needs are being met by the right professional. It also allows the family or the patient to have a connection with a series of professionals in that clinic. So perhaps the physician isn't available on that given day, but their need is appropriate to start with the nurse. So they would be able to access somebody that's familiar with them, familiar with their, family history, and it's a relationship is already established with that team. Providers also find it very supportive in that they have a community of practice and other team members that can support them to really optimize their delivery of care. It's being seen across the country and certainly in Nova Scotia as a highly successful model.
We have 20 seconds left. Mr. Taggart.
So I just want to further that comment a little bit, if I could, because I've actually worked with Ms. McCormick and others at Northern Region to solve our problems. And so one of the challenges, I think, with bringing primary care physicians to rural areas is they don't want to work by themselves. They let
Order. Time for questioning by the PC Caucus has elapsed. I want to thank everyone for appearing today. We know that you're very busy right now, and we do appreciate you taking time to appear before the committee. There are a number of questions that we didn't have answered. Oh, Mr. McGuire?
Thank you, Madam Chair, and I think this was, I don't mean to interrupt, but I think this was kind of on the par with what you were going to say, and we've had discussions over the last month about the way this committee should work and how it should work and the role of the chair. 15 questions were put to the witnesses that were not answered. 15 questions, which might be an all-time record here. We've spoken as a committee that when witnesses do not have the answers, when we'll say are unprepared to answer those questions, that it's within their purview of the chair to request that they come back. And so what I will say about today's meeting is we did request that Ms. Oldfield be here today, and unfortunately Ms. Oldfield is not here. We have 2 members from the Nova Scotia Health Authority who did a great job, but ultimately the questions that we put forward should be answered by Ms. Oldfield, and we had 15 questions today that we were told they don't have the answers to. So I'm requesting that you as the chair ask that the witnesses reappear along with Ms. Oldfield at the soonest possible date for public accounts, and that could, maybe we could push off one of the Auditor General's hour-long, review of topics, and have them reappear. I think it does a disservice to this committee, and it does a disservice to Nova Scotians, especially on healthcare, which is the single most expense in the province, that we have witnesses here that can't answer some of the simplest questions. So the motion on the floor is that we, or I don't know if it has to be a motion or so the motion on the floor will be in spirit of cooperation. We talked about this as a committee, that when the witnesses appear before this committee that are unprepared and can't answer questions, that we are to bring them back, and it's up to the chair to do that. And I think the chair can rule outside of a motion. So I'm asking that these witnesses appear at the soonest possible date that the committee has to come back and answer these questions.
Thank you, Mr. McGuire. Mr. Young?
Thank you. Just with respect to how this committee typically functions, at times when the witnesses are unable to come up with have an answer, have the material ready for them at the time, we've submitted in the past a request to have some information submitted forward. The topic was impact on government expenses for ER understaffing is what the topic was today. Perhaps some of those questions may have not been in the purview of the topic today, but what I would state is just the function of the committee has been, when we hadn't had all the information provided, that the chair would follow up with the witnesses to gather the information to share with the committee. So I would expect normal practice to be followed.
Mr. McGuire.
So again, I will say, if you think that normal practice is witnesses not being able to answer 15 questions in regards to the IWK emergency room and the QEH emergency room, then you are woefully wrong. We've had these conversations, and the government side has asked this side of the House to trust them in these changes, and now are doing a complete 180. Part of the discussions that we had was that it was with the Auditor General and with the government, who agreed that when witnesses did not come prepared or have the answers to questions, that we would call them back. And now, at the first opportunity, when 15 questions went unanswered, the government is now going to vote against it, and you expect us to trust that these motions the changes that you want to make to this committee. So we're asking you to stand by your word that we will be able to call witnesses back. And in fact, maybe we can have Mr. Hebb look into it. I don't even think we need a motion. I think it's up to, and that's what we heard in training, that it's up to the chair, solely up to the chair, to be able to recall them back. And I ask that the chair look into it.
Thank you. So, in the past, what we have seen is that we have sent a letter and we have expected responses. We're in the process of changing over to something new. So what I'm going to say is this. We have a number of questions, many of which were not answered here today. We want answers by the end of the week. If we don't get answers by the end of the week, we will recall the witnesses, including, and this will be the only time this happens, where we don't recall them. We have to ensure that when witnesses come before us, they can answer questions, and that and that we get them in a timely fashion. So I'm going to write a letter outlining all of the questions that weren't answered, and then we will take our actions from there. This is a shot across the bow. I'm not having any more discussion. We have a whole lot of business to get to. We're going to move. Thank you very much to our witnesses. We really appreciate you coming out today and sharing everything with us that you did. We are now going to move into committee business, which we have a lot of. So, Our first up first is the road mapped motion. So members have been provided with a proposed roadmap to build a more effective PAC culture in Nova Scotia. I'd like to open the floor for discussion on the proposed roadmap. Any further discussion on the proposed roadmap? I think we've discussed it to death. Would anyone like to make a motion on the roadmap? Mr. Young.
You know, I'm quite pleased with the work that the Auditor General had put within this roadmap. Very pleased. I'm very pleased with the cooperation and collaboration and the training sessions that we've had as a team, as a PAC committee, as a functional PAC committee in some of the training. We are in support of this roadmap. This is something that our party would support. If someone's willing to make a motion, we would happily support it.
Mr. McGuire?
I'll just, maybe for people here today, the Auditor General can read the motion, or read the roadmap and specifics of it so people know. But I will say, like, the very first test that we put it to, it failed. So it hasn't passed. So it may not have passed, but this is exactly what I was concerned about, and I talked to the Auditor General and staff about would happen. The reasoning behind this today from the members opposite was, well, the normal procedure is to ask for these questions and get the response. We know that we've asked for responses from Ms. Oldfield, and we're still waiting. I think over a month.
No, it was there.
In the package.
It's in the package. So we had to wait a considerable amount of time. And so we continue to, you're asking that we put our faith in the government's hand, that everything they've asked to change on this Public Accounts Committee favors government, and yet they think it's acceptable that 15 questions went unanswered today. So this was exactly what I was concerned about and worried about, is that we'd go down this road. And we heard the questions today from the government. They weren't exactly probing questions. They were pretty government-friendly questions, which, again, was something that we were told they would stop doing. And so I mean, the motion's going to go. I'm also concerned that we're not going to be able to bring topics in a timely manner. I'm not going to filibuster. We're going to have this vote. But I was elected to, and I'm on this committee to bring forward concerns that come forward from the public. And while I agree that some of these issues are important, they're all important, there are pressing issues. And there are pressing issues right now to Nova Scotians, including climate change, carbon tax, which the Auditor General is doing something on, but also inflation, housing, all these different issues. I would argue that QE2 redevelopment and things like that, and we're just not going to be able to bring them forward in a timely manner. And that's one of the concerns that I have, that for how many years that this committee has existed, including the 9 years that I've been on it, we've been able to effectively debate in camera topics and bring forward a list of topics. And now, over the last year, we're being told that that is not an effective way to bring forward topics. And so those are my concerns, and I'd like to register them on the record that I think that we were elected to do a job, and part of that job is this committee.
Thank you, Mr. McGuire. Any further discussion? Would anyone like to make a motion regarding the proposed roadmap?
And can we get her to read the roadmap as requested?
We have a lot of, do you mean the step one, or you don't want the whole thing read out into the record, do you? That would take forever. And we have a fair amount of business. Ms. LeBlanc.
Thank you, Madam Chair. I'm not ready to make a motion on this, and I don't know that anyone else is today. I'm wondering if we can defer this to another meeting.
If it's the will of the committee, if there's no consensus on this? Mr. Young?
I mean, we've had countless informal discussions. We had countless training discussions. You know, I think I've really heard from every member on this committee and their intent and their feelings towards this independent roadmap. It's not something that the PC party is driving. This is something that's coming from not only the independence of the Auditor General, but the CCPAC, the CCAAF, and these are some of the best practices that are across the country and the world. And with respect, I'd just like to hear from some of the other members of the committee to see, you know, we've talked about these things in the past, just to see where we stand. Thank you.
Ms. LeBlanc, and I am going to put a time limit on this simply because we have other committee business that we actually have to attend to that has a time limit on it. So, Ms. LeBlanc?
The NDP Caucus is in support of this roadmap. We want to support it. We are not putting the motion on the table. The government has a majority on this committee, and we hope that the government, if they are in support of this motion, will make the motion.
Thank you very much. Any? Mr. Young?
I'm just curious on where the Liberal caucus stands. I know as the chair you don't normally engage in debate or Mr. McGuire, but through some of the informal conversations and whatnot in the past, it seemed to be that there'd be consensus amongst everyone, but I'd just like to hear from our Liberal colleagues, perhaps.
Mr. McGuire?
I think I've said enough.
Mr. Young. Mr. Young. Mr. Taggart.
Well, it sounds like we're in one of those gotcha moments that we thought we weren't going to do. So there you go.
Make the motion. Make the motion.
So that you folks, so, you know, so the deal here is, and I'll be frank, you know, the idea here is that, you know, we want us to make the motion so the media can say, well, the PC did their thing and they blocked this and they blocked that, and you know, so if we want to go back, I haven't been here. I'm new to the committee, but if you know, if that's what we're going to do, that's what we're going to do. I'm just it's disappointing. That's all I can say.
Mr. Taggart, I assure you, I will not say that. Mr. McGuire.
I mean, to be clear, I think I've been very clear. I mean, we're talking about gotcha moments. This is why you're asking me to say what I can say. So you can put it on Twitter with whatever. I'll be very clear, so there's no misinterpretation of how I feel. I am not in favor of this, and I'm not in favor of this. And everybody can get on their phones and tweet that out. And I'm not in favor of this. And people can say whatever they want, and I'm not in favor of this because, and I've been very clear from day one, so nobody needs to act surprised across there. I've been very clear. I'm not surprised because I put it to the test today. You failed.
You failed.
I'm talking. I put it to the test today on the questions, and it was a failure. And second of all, I'm not comfortable, and I don't think anyone should be comfortable with giving up topics that people in Nova Scotia bring to us. And it's important that we're able to bring topics in a timely manner. If we want to talk about the redevelopment of the QE2, we shouldn't have to wait 2 or 3 years to when it's not a pressing topic and we're $1 billion into, or $1 billion over budget, or $2 billion over budget. We should be able to bring those things forward in a timely manner. And I've been very clear on this. Public accounts has always worked topics. Listen, I know it's not easy. I know it's difficult to not always get your way. But that's what in camera's for. We're frank with each other.
Order. I think we understand where.
I'm not finished.
That's fine. We're moving on to another topic. The time that is elapsed, I was very clear, we are not spending the whole half hour on this particular issue. We're going to set it aside and move on to witnesses for the 2022 financial report of the Auditor General. We'll be meeting with the Auditor General on December 7th regarding the annual financial report. The next week, December 14th, the witnesses suggested to appear by the Auditor General is the Department of Finance, which the committee has not yet approved. So I am looking for a motion to approve the Department of Finance as the witness in relation to the 2022 financial report of the Auditor General. Mr. MacDonald?
I move that the witness be the Department of Finance.
Thank you, Mr. MacDonald. Any discussion? All those in favor, please indicate by saying aye. Aye. Contrary-minded, nay. The motion is carried. Endorsement of Auditor General recommendations, Immigration and Population Growth Report. The committee's practice is to endorse the recommendations made by the Auditor General. This is the committee's first public meeting since the Immigration and Population Growth Report was tabled where the committee can do so. So I'm looking for a motion to endorse the recommendations. I do see Ms. LeBlanc.
No.
Oh, Mr. Young? Okay. Mr. Young?
Yeah. I move that the Public Accounts Committee formally accept and endorse recommendations contained in the 2022 report of the Auditor General, Immigration and Population Growth, that have been accepted by the audited departments or agencies, and ask that those departments and agencies commit to and take responsibility for in full and timely implementation of the recommendations accepted by those departments.
Any discussion? All those in favor of the motion, please say aye. Aye. Contrary-minded, nay. Motion is carried. The 2022 annual report was circulated to members previously, I think about a month ago, and it's now ready to be approved. So I'm asking for a motion to approve the 2022 annual report for the Standing Committee on Public Accounts. Mr. MacDonald?
I move we approve the 2022 annual report.
Thank you. Any discussion? All those in favor of the motion, please signify by saying aye. Aye. Contrary-minded, nay. Motion is carried. Now we move on to meeting schedule, December and January. The committee schedule for the upcoming holidays, etc., should be decided. Typically, the committee doesn't meet the week before Christmas, the week of Christmas, and the first week of January. So that would be no meetings on December 21st, 28th, and January 4th. And then the first meeting in the new year would be January 11th. Any discussion on that? Do we have to have a motion on that?
If you can agree, but.
Yeah, we're all good.
We're all good? Okay, so we will, no meetings December 28th, 21st, 28th, and January 4th. Our first meeting back after Christmas would be the 11th. Mr. Young.
Madam Chair, I'd ask for a 4-minute recess.
Okay, thank you. 4-minute recess.
We agree to the schedule, right?
Yeah. Yeah, yeah. Order. Now call the committee back to order. Couldn't figure out what was going on there. Okay, we do have some correspondence here. The Nova Scotia Gaming Corporation, information requested from the October 12th, 2022 meeting. There was also information from the Department of Education and Early Childhood Development from the October 26th meeting. Nova Scotia Health, information requested from the October 5th, 2022 meeting, and the Department of Communities, Culture, Tourism, and Heritage, information requested from the September 7th, 2022 meeting. Any discussion on any of the correspondence? I do have a problem with some of the response from Nova Scotia Health, which basically kicked it over to the healthcare redevelopment in Nova Scotia website is managed by Communications Nova Scotia, and questions should be directed to them. I do feel that we have no knowledge of whether they've actually sent anything there, so I do think that I probably need to write to Ms. Oldfield and request further information about her response there. So I will do that. Any other discussion on any of the correspondence, Mr. Young? Okay.
Actually.
Yeah. Oh, Ms. LeBlanc.
Well, in the letter, she says refer to the attachment of the table of meetings, but I don't see the attachment, the table of meetings attachment. Okay.
Oh, it may not have been printed. I think was it sent out to people? We're not sure, but we will make sure that attachment gets sent out
Thanks.
to you. And if there are any questions that arise from that attachment, please bring them up at our next meeting, okay? So we will accept those with the caveat around that first answer from the November 4th letter from Health. So, so then we can move on to our next meeting date, which is November 30th. The Department of Labor, Skills and Immigration and the Immigrant Services Association of Nova Scotia will be in on the 2022 report of the Auditor General, Immigration and Population Growth. Just so everyone knows. Is there any further business? Good job, everybody. All right, so I will now adjourn the meeting. The meeting is adjourned.